He is the chairman and founder of the Weill Cornell Brain and Spine Center, absolutely the leading neuroscience patient care center in New York City. And I cannot believe what we're talking about. I have talked to so many people I know about this, and I know they are tuning in to hear about it. How about brain surgery while you're awake? Wow. And feeling no pain, because the brain apparently doesn't feel any. But the expert is with us. So, Dr. Stieg, thanks so much for coming on. And it just doesn't seem right to say, hey, you have brain surgery and you're awake and the brain doesn't feel any pain, but you're the expert. So tell me how that's possible.
Well, I mean, you summarized it. The fortunate part is that we keep you asleep and we use local anesthetic agents while we're getting there, meaning for the skin incision and for the bone work. But fortunately, the brain itself doesn't have any pain fibers. So when we're working on that, we can keep you awake, and there are specific reasons we can talk about why we have to do that.
Yeah, let's talk about that. Why do you have to do that?
Well, many times there are lesions in the brain, tumors or vascular malformations that are located very close to what we refer to as eloquent parts of the brain. And by that I mean the parts of the brain that are important for speech and for motor function. So we do have functional MRI scanning, which helps us determine preoperatively whether the lesion is in or close to those areas, but that is not a completely accurate science. So we choose to do the surgery awake, and then when the patient is awakened at the time of removing the lesion, we can stimulate right around where that tumor or that vascular malformation is and determine whether that's important brain. If it is, we have to change our tack and go in from a different direction.
So while you're doing this brain surgery and maybe changing your tack, that kind of stuff, the patient they're fully awake, right? They're aware of what's happening, and are they conversing?
Fully awake, they have to be fully awake and fully conversant, because we're assessing, while I'm operating, the patient is under all the drapes, and under the drapes, which are lifted up by certain rods so that our neuropsychologists and anesthesiologists are right there, and they can interact with the patient. And they have conversations. We have them do formal kinds of testing, like reading complex sentences, counting, and then we just have a specific dialogue with them. While we're taking out the lesion, they'll just keep small talk going. If we're working in something like the motor cortex, we would have the patient continually moving their toes or squeezing their hand and moving their arm.
Well, when you tell patients that, what's their reaction?
It's mixed. Some of them, by the time we've gotten to the conversation about doing the operation awake, they fully understand the importance of having to do that. I've shown them the MRI scan. I show them how close the abnormality they have is to that important part of their brain. And obviously, they don't want to lose any neurologic function as a result of the surgery. So, they're willing to go through it. Obviously, nobody really wants brain surgery. So they enter the conversation with a fair amount of trepidation to begin with. But then they understand it.
Yeah, so once they understand that, do they realize, I'm wondering, is this a trend? How long have you been doing this? And is it, more surgery without kind of cutting?
This has been going on for over 50 years. It's the trend now has been to do more awake craniotomies or brain surgeries, because what we have learned is we used to think that there were very specific areas for speech. And now we've learned that throughout specific parts of the brain, even though speech is located in one particular area, refinements of your and my speech patterns can be distributed throughout areas of the brain. So we really want to be specific to try and not hurt a patient in any way.
Yeah. So if you say for over 50 years this has been happening, but it's still, for a lot of people new hearing this, because as you said, who wants to have brain surgery? And it's always shocking when someone hears that and then going through what you have to go through to get yourself ready for it mentally. I wonder how the practice overall of brain surgery has changed, because obviously you're at the forefront of all of this. It's been incredible advancements, right?
Well, I think the advancement of the functional MRI scan has actually, to a certain degree, eliminated some of the cases that we would have done awake. We can get the functional MRI scan and see that we've got several millimeters to a good centimeter of space between what we consider the lesion and what we consider functional cortex. So in those scenarios, if we can offer it to the patient, we'll say, let's do this asleep. But the electrodes that we use and the micro instruments that we use are all significantly better just in the 30 years that I've been doing it.
Yeah, so especially talking about the MRI and the advancement there, when that's obviously part of the planning. What else goes into the planning and trying to make the decision of whether we're talking about a patient is going to be awake or they shouldn't be awake?
It depends upon the lesion. If it's a vascular malformation, we may need to do an angiogram, and sometimes if this vascular malformation is close to the speech cortex, we may do what's called an amytal test, where we put a drug into the arteries and see whether they lose speech. There are multiple techniques that we use for really trying to refine the functional areas of the brain. So that has all made this a much more specific science over the years.
Yeah, specific science. That's what makes me wonder, are our brains basically designed and kind of built the same, or no, they're completely different, or some are different?
They're pretty similar in the sense that the things that we're worried about from a functional standpoint, so we always know where the motor cortex is. So it's in our posterior frontal lobe, and the two dominant areas of speech. One area is in the inferior frontal lobe, and one is in the temporal lobe. But as I said earlier, those are the dominant areas, and they're usually, in terms of speech, it's usually 97% of the patients is on the left side of the brain. In those rare circumstances where patients are left-handed, the speech cortex can actually be on the right side. But again, it's the intricacies of our speech patterns in that. That's why we have to map these things out, and it's very important in seizure surgery and, as I said, in the resection of these vascular malformations and brain tumors.
Yeah, so when you go in and you do this, and you're someone who's done this so much, when you look at the procedure, is it more or is it less riskier than surgery?
Well, the reason for doing the awake craniotomy is to make it less risky. If I feel that there's any risk, as a patient I just saw today, I feel that the lesion that they have is very close to a specific part of their speech cortex. Rather than take the chance and me go in with them asleep and unable to test them, I will talk with them about doing the surgery awake. So in essence, it reduces the risk for the patient, but it temporarily increases the anxiety. Again, I'll state, however, that most patients, as long as the surgery doesn't go on too long, you have about a good 4 hours. You can take it on longer, but then it gets a little bit uncomfortable for the patient to be laying in one position for that period of time when they're awake. But they really tolerate it quite well.
I wonder for you, it's got to be, it's like we talk about what are the rewards for what we do for a living. And I can imagine that it must be incredibly rewarding for you to see what's happened with some people's lives after the procedure. I'm sure you've got a couple of cases that just really stick out in your mind. Is there one where you said, wow, this is one of my proudest moments, and I love the way this patient came through? Was it the first time you did it and was successful, or when would that be?
Oh gosh, I remember we all start with a simple case, fortunately. So my first neurosurgical case was quite simple, but there was a proud moment when I had finished my residency and gone on and done it all alone. Just this past week, operated on a police officer that had a massive, thank God, benign brain tumor that was wrapped around her brainstem, which is basically the Penn station of your brain, where everything comes into your brain and goes from your brain down into your spine. And when the patient wakes up with no neurologic deficit, they leave the hospital in 2 or 3 days. It's obviously a satisfying feeling. But, yes, that's extremely fulfilling, and thank God with the refinements in surgical techniques nowadays, it happens much more often than it certainly did when I first started my career.
I bet. What does a brain surgeon do for fun? How do you relax?
I love to play golf. I love to play tennis. And most importantly, I love to spend time with my children.